So today also going to start antihypertensive drug. So hypertension, is the commonest cardiovascular disease in which there is a persistent rise in the blood pressure, and both systolic and diastolic blood pressure are important, and rise in either has a damaging effect. If systolic blood pressure is more than 200 or more, or diastolic blood pressure is more than 120, it is labeled as severe hypertension. And systolic blood pressure is due to circulatory volume and heart rate, while diastolic blood pressure is due to the peripheral vascular resistance. So BP should be measured at least 2 to 3 defined occasions and every time, 2 to 3 defined positions, recumbent, sitting and standing, and then diagnosis should be made. And blood pressure should be measured after assuring, so that they have and at the relaxing stage. And if blood pressure is measured immediately or shortly after arrival of the patient to the hospital or clinic, BP may be transiently raised due to sympathetic stimulation. That is called also white coat hypertension. So whatever may be the hypertension, not a single measurement is not so much important unless BP is too much high, above 160, 170, or systolic or diastolic more than 100. If it is below that level, a patient was not previously normotensive, then we have to check the blood pressure again to confirm that patient actually has hypertension, because often due to sympathetic stimulation in hospital or in clinic there can be transient rise in the blood pressure, that is called white coat hypertension. Hypertension is the most common cardiovascular condition, and its proper treatment is essential to protect the heart, brain, kidney and eye. Most of the time hypertension, it has no particular cause, that is called, we call it them primary hypertension or essential hypertension, and it consists of 95% of cases. But secondary hypertension is due to specific cause and for which treatment of that cause is important, otherwise blood pressure will not be controlled. What are the causes? Common causes are hypertension of the secondary hypertension are pheochromocytoma, Cushing syndrome, thyroid disorders, primary hyperaldosteronism, and some renal disorders like polycystic kidney, some vascular disorders like coarctation of aorta, and also Cushing syndrome, etc. They will cause secondary hypertension. Now, what is hypertension? So, though there are multiple guidelines, but still now we Indians follow the JNC7, and as per that, blood pressure, normal blood pressure is systolic less than 120 and diastolic less than 80. And if it is more than 120 systolic up to 139 diastolic, up to 139 systolic, so systolic 120 to 139 or diastolic 80 to 89, then we call it as pre-hypertension. That means that is the stage patient has not developed hypertension, but he has to take some precautionary measures to prevent the development of the hypertension. And there is hypertension stage 1. What is that? Systolic 140 to 159 or diastolic 90 to 99. That means 20 range in the systolic and 10 range in the diastolic. That is called pre-hypertension stage 1. Whatever, and we take it as higher, either of these values. Suppose blood pressure is 150, but systolic is 150, diastolic is 84. Then we also patient is at hypertension stage 1, because this systolic BP is between 140 to 159. But if it is 130 to 100 by 130 by 100, then as per the diastolic blood pressure, as it is between, so suppose it is 130 by 96, suppose if it is that, this is also stage 1 hypertension as per the diastolic BP. So elevation of both is not required. Elevation of either of these two will stamp a patient as hypertension stage 1. Similarly, hypertension stage 2, if it is systolic between 160 to 179 or diastolic 100 to 109, then we call it as hypertension stage 2. Because okay, so that means if it is, suppose it is 160 by 92, then also it is hypertension stage 2 as per the systolic BP. Similarly, if it is suppose 140 by 106, then also as per the diastolic BP is at the stage 2 hypertension. Okay, so remember this classification: 82 systolic below 120 and diastolic below 80 is normal. If it is 130 to 139 systolic or 80 to 89 diastolic, then we call it is pre-hypertension. 140 to 159 systolic or 90 to 99 diastolic, then we call it a stage 1 hypertension. 160 to 179 systolic or 100 to 109 diastolic millimeter mercury, then we call it as hypertension stage 2. And if it is diastolic BP is more than 120 millimeter mercury, it is hypertensive crisis. So hypertensive crisis is a term which is called, if it is systolic is more than 180 and diastolic is more than 120, then it is a hypertensive crisis. And hypertensive crisis can be divided into two parts. One is hypertensive urgency and hypertensive emergency. So what is that? So please make it clear. So hypertensive crisis is any blood pressure above 180 by 120, and if it is associated with some target organ damage, that means there is sudden onset renal failure, sudden onset hemorrhagic stroke, or in eye there can be the development of the papilledema, or even in heart if there is myocardial infarction due to this elevated blood pressure. Then so this target organ damage, that means heart, kidney, brain and retina. If there is damage of this target organ associated with some elevation of BP, then we call it as hypertensive emergency. And if it is blood pressure is only elevated but there is no target organ damage, then we call it as hypertensive urgency. So hypertensive crisis is the broad term. If it is associated with target organ damage, then we call it hypertensive emergency. If it is not associated with target organ damage, like target organ means here heart, kidney, brain and retina, then we call it as hypertensive urgency. So hypertensive emergency should be treated very promptly, preferably within hours, to control the blood pressure, whereas hypertensive urgency can be treated, blood pressure need to be controlled within some days. And hypertensive urgency to be treated with oral drug, hypertensive emergency we have to treat it by IV drug. So this is the physiology of hypertension. So there is a role of the renin-angiotensin system. Aldosterone overproduction will cause sodium and water retention, and that will cause increased plasma volume, which will cause increased blood in the blood pressure. Central mechanisms, also there is stimulation of the sympathetic ganglia and postganglionic adrenergic nerve endings that will cause alpha receptor stimulation, that will cause vasoconstriction, and that will increase the afterload and increase the blood pressure. Also beta receptor stimulation can cause increased heart rate and cardiac output, that will also cause increase in the blood pressure. So how we can control the blood pressure? Either we have to decrease the blood volume, or we have to decrease the vascular tone, vasodilation, or we have to decrease the cardiac contractility and heart rate. So classification of antihypertensive, that is very important. So angiotensin converting enzyme inhibitors, example we have discussed already: captopril, enalapril, lisinopril, amipril. Angiotensin 2 receptor antagonists like losartan, telmisartan, olmesartan. Calcium channel blockers: verapamil, nifedipine, amlodipine, diltiazem. Next is diuretic. Remember here thiazide diuretics are preferred over loop diuretics. Those both can be used, but in the long term use thiazide diuretics are preferred over loop diuretics. 5. Sympatholytics, it can be divided as alpha blocker, beta blocker. Alpha blocker example is prazosin. Beta blocker example metoprolol, atenolol, nebivolol, bisoprolol. And vasodilators, it can be arterial dilator or venodilator. So thiazide, so example is hydrochlorothiazide, chlorthalidone. Loop diuretics, furosemide. Potassium sparing diuretics also you can use, that is the spironolactone, amyloidine, trimethoprim. So spironolactone is the aldosterone antagonist, and amyloidine, trimethoprim are potassium sparing diuretics. That means they will conserve the potassium, unlike the other diuretics which will lose the potassium. So sympatholytics, centrally acting is also there, clonidine and methyl dopa. Adrenergic receptor blocker, alpha blocker, beta blocker, and there are some combined alpha beta blocker. Example is labetalol. Vasodilators, there is hydralazine, minoxidil, diazoxide. Arteriovenous dilators is common. So remember, so there is minoxidil, hydralazine, diazoxide. They are preferential arterial dilator. Preferential venodilator is nitroglycerin, and whereas arteriovenous dilators, that means mixed dilators, are sodium nitroprusside. Also ACE inhibitors can be regarded as mixed dilators. So now we shall come one by one how all the antihypertensive works. Most of the drugs already known by you in the different classes. We have discussed RAS, we have discussed calcium channel blocker, we have discussed beta blocker already. So just recapitulation. So angiotensin converting enzyme inhibitors inhibit the generation of the angiotensin 2 from angiotensin 1, and as angiotensin 2 is not active, so all the actions of the angiotensin 2, that means they are direct vasoconstriction action, they are aldosterone production action, and also they are increased sympathetic, they sensitize the effect of the norepinephrine on the vascular smooth muscle. All effects are lost. So they inhibit degradation of the bradykinin also, which is a potent vasodilator, and it dilates both arteries and veins, blood. So as a result, there will be more perfusion to the vital organs. They decrease aldosterone production by inhibiting the angiotensin II action. So if you remember all the angiotensin II action, so predominantly I have discussed the rapid pressure response and slow pressure response. So rapid pressure response means which are affected at the level of the cardiovascular system, that means direct vasoconstriction, also increase the sensitivity of the norepinephrine on the vascular muscle by causing the release of, also increasing the release of the norepinephrine, decreasing the reuptake of the norepinephrine, and this is the rapid pressure response. Also they increase the central sympathetic outflow, angiotensin II. All is inhibited if we give ACE inhibitor or ARB, and additionally there is also decrease in the aldosterone production, which will cause decrease in the salt and water preservation in the body. So all our drugs are products except captopril and lisinopril, and they are well absorbed. Food reduces absorption of captopril. Also captopril is short acting, so need to be given repeatedly, and so that's why as an antihypertensive we commonly prefer enalapril or ramipril, which having longer action, duration of action, and all are excreted through the kidneys. So in renal failure patients, its dose should be reduced. These are the common adverse effects. Dry cough, it is due to excess accumulation of the bradykinin because bradykinin metabolism is depressed. Angioedema, it can cause some taste alteration in the tongue. It is teratogenic, so I have must be avoided during pregnancy. Hypotension can happen in the first dose, that is first dose phenomenon, because of the more shift of the blood in the lower extremity if patient is remain standing after taking the ACE inhibitor. It can rarely cause some idiosyncratic reaction like neutropenia, rashes, itching, and hyperkalemia. We have to exclude that. So before starting ACE inhibitor and also during ACE inhibitor therapy, you have to check the potassium level. If it is hyperkalemia, then you have to avoid the drug. What are the advantages of ACE inhibitor? So lack of postural hypotension is not, though it is theoretically present, but not so common like prazosin. Prazosin is alpha blocker that is causing more postural hypotension. It is safe in asthmatics and diabetics. Beta blockers we cannot give it in asthmatics. Also, beta blocker and thiazide cannot be given in the diabetes or not preferred in diabetes. And decrease incidence of type 2 diabetes in high risk cases. It has been seen that ACE inhibitor is the drug of choice in the diabetes patients, especially with the nephropathy. They prevent potassium loss due to diuretics, reverse the left ventricular hypertrophy, that is additional mechanism, and no hyperuricemia or derangement of lipids. So diuretics, we know that they tend to cause hyperuricemia or derangement of lipids. ACE inhibitor is not having such effect. There is no rebound hypertension unlike beta blocker. Beta blocker we cannot stop it suddenly because there is chance of development of the rebound hypertension, and beta blocker overstimulation or supersensitivity of the beta receptor is there, which is causing increased heart rate and sudden development of the MI or angina. And also there is no effect on the sexual function of the male also. Beta blocker thiazide tend to cause some erectile dysfunction. That's why we have to be cautious. So these are the advantages of the ACE inhibitors. And what are the uses? We have discussed already hypertension. That is the first line drug for all rates of hypertension except in pregnancy and in hyperkalemia, but especially indicated in hypertension and diabetes, because in diabetes it is found to reduce the nephropathic progression of the nephropathy. That means the changes in the kidney, which is due to the proteinuria. It reduces the proteinuria, that's why, and proteinuria will cause some changes in the kidney. The excess ECM production that will ultimately cause decrease in the GFR. That pathway is blocked by the ACE inhibitors. That's why proteinuria induced changes in the kidney that is reversed by the ACE inhibitor. That's why diabetes with nephropathy, ACE inhibitor is a drug of choice. Also, if hypertension associated with left ventricular hypertrophy, then also ACE inhibitor should be given, because ACE inhibitor, by reducing the angiotensin II and aldosterone action, they will reduce the deposition of the extracellular matrix and they will cause prevention of the cardiac remodeling. That's why left ventricular hypertrophy patients, they tend to progress less to the heart failure. So heart failure prevention is also done by the ACE inhibitor, and diabetes patients also are prone to development of the heart failure. Congestive cardiac failure, If it is already present, then also SC inhibitor should be given. Myocardial infarction, because of damage of a significant part of the ventricular wall, there is development of heart failure, and myocardial infarction patients, if it is SC inhibitor is given, they tend to improve the survival. Diabetic nephropathy already we have discussed, and scleroderma renal crisis, that is another emergency situation when there is sudden development of the renal failure in the scleroderma patient due to renal vasoconstriction. SC inhibitor by which vasodilated action improves that. So these are the uses of the SC inhibitor: hypertension, heart failure, myocardial infarction, diabetic nephropathy, and scleroderma renal crisis. Next, similar group of drug but less potentiation of bradykinin action is done by the ARB or angiotensin receptor blocker. Example is losartan, telmisartan, olmesartan, valsartan, and AT1 receptor are blocked mainly, which is involved in the vasoconstriction, aldosterone secretion, and release of the norepinephrine. So angiotensin 2 cannot act on the AT1 receptor if we give ARB. So there is less vasoconstriction, less aldosterone release, less secretion of the norepinephrine. So there is vasodilation. AT2 receptor, so now ARB blocks only AT1 receptor. AT2 receptor remains unblocked, and it is believed that AT2 receptor probably has some role in the vasodilation. So they will have reverse action of the AT1. Thus, it can have some vasodilatory action which will help in the perfusion of the other organs. ARB are competitively inhibit binding of the angiotensin 2 and AT1 receptors. So remember, angiotensin 2 action is blocked by ARB as they prevent their angiotensin 2 action on the AT1 receptor. Use and effects are same and mainly used in patients who are intolerable to, who cannot tolerate SC inhibitor due to cough or angioedema. So SC inhibitor is preferred. If SC inhibitor cannot be tolerated, then only give angiotensin receptor blocker, because SC inhibitor has additional action of their bradykinin, which is causing side effect, but actually it is very beneficial also, because bradykinin effect will cause vasodilation and will promote further decrease in the blood pressure and further improve the perfusion of the organs, which ARB cannot. So that's why SC inhibitor, if patient can tolerate, that is the better drug, but ARB is safer drug. So as per the patient's profile, we can select both the drugs for the treatment of the hypertension. So adverse effect: headache due to vasodilation of the cranial vessels. It can cause hypotension. Hyperkalemia is common to SC inhibitor and ARB both, and it is also teratogenic, so cannot be given in pregnancy. So calcium channel blockers, there are three types of calcium channel blockers: dihydropyridine, benzothiazepine, and phenylalkylamine. So examples of dihydropyridine: nifedipine, amlodipine. Benzothiazepine we have diltiazem, and phenylalkylamine we have verapamil. So verapamil and diltiazem, they are less commonly preferred antihypertensive, but it can be used sometimes. So what is the difference? So dihydropyridine mainly their action is concentrated on the vascular smooth muscle, whereas diltiazem and verapamil mainly their action is concentrated on the heart. So verapamil, diltiazem mainly decrease the heart rate, decrease the contractility, and thereby reducing the cardiac output. That helps in the reduction of the blood pressure. But nifedipine, amlodipine, they reduce the they cause the vasodilation. So there is decrease in the preload afterload, mainly afterload, that is improving the that is causing the decrease in the blood pressure. So mechanism of action: they decrease the peripheral vascular resistance without compromising cardiac output, and this is called vasodilation. So calcium channel blockers, mainly this dihydropyridine group, nifedipine, amlodipine, they decrease the peripheral vascular resistance, and there is no decrease in the cardiac output. Adverse effects: headache, flushing, tachycardia, and palpitation. The sustained release preparation have less side effects. So nifedipine previously, which we used, that was short acting. Nowadays modified release nifedipine is used, but this short acting dihydropyridine, they have some problems of this headache, flushing, tachycardia, palpitation due to vasodilation. So why there is tachycardia? Because of this significant vasodilation, there is sometimes reflex tachycardia, reflex sympathetic stimulation, and that is absent with the longer acting drugs like amlodipine. So beta blockers often is added to SC inhibitor to counteract the reflex tachycardia, and it is useful in the patients of the angina, asthma, peripheral vascular disease, migraine, hyperlipidemia, and diabetes. And it has the least adverse effect. It can be given in all the patients. This amlodipine, there is no contraindication in the pregnancy, no contraindication in the hyperkalemia, no contraindication in the diabetes, no contraindication in the hyperuricemia, no contraindication in the hyperlipidemia, like that. So it can be given in all patients, but we have to check whether there is reflex tachycardia or not. And amlodipine group of drug, they are prone to cause ankle edema due to vasodilation in the capillary vasodilation in the capillaries. There is exudation of the more water from the capillary into the outside. So there is ankle edema, but that is actually depending on the dose. If we can decrease the dose and add the other antihypertensive, these effects generally subsides. And remember, this ankle edema due to amlodipine is not reversible with the diuretics. So addition of the thiazide or furosemide will not benefit much. We have to either stop the drug or reduce the dose. Diuretics. So we have discussed calcium channel blockers, nifedipine, amlodipine. Diltiazem can also be used because if the already patients having tachycardia as well as associated with hypertension, then diltiazem can take care of both. So diltiazem will cause vasodilation as well as they will decrease the heart rate and cardiac output, and that's why it can be preferred in some patients. But the problem is that it can, if it is the heart rate is not monitored, it can cause bradycardia, and if a patient is already having some kind of heart block, diltiazem will aggravate that. That's why diltiazem, before giving diltiazem, ECG should be done, also heart rate should be assessed, otherwise we cannot give it the diltiazem. Also remember, diltiazem, verapamil, they must be avoided with beta blocker, because if we give beta blocker and diltiazem both, then there will be significant drop in the blood pressure, significant drop in the cardiac output, there is precipitation of the heart block as well as heart failure. Because both diltiazem, verapamil as well as beta blocker, they will cause dysfunction of the sinus node, they will slow the heart rate, they will cause significant decrease in the contractility, which will cause significant drop in the cardiac output, and that's precipitate heart failure. Diuretics. So all the diuretics can be used as antihypertensive, especially thiazide diuretics, furosemide and spironolactone, but thiazide diuretics are preferred here. Why? So it is just like reverse of the heart failure. So in heart failure there is accumulation of the excess water and salt, which we need to eliminate by furosemide, because furosemide or loop diuretics will cause, as they are high filling diuretics, they will excrete more water and salt if dose are increased. And as heart failure patient, there is significant accumulation of the water and salt. So without furosemide, thiazide cannot eliminate it properly. But in hypertension patient, there is no significant volume retention. So here excess salt and water is accumulated, but that is not of significant type. That's why thiazide is used, because thiazide will cause moderate salt and water elimination, unlike furosemide, which will cause significant elimination of the salt and water. And the problem of furosemide on chronic use is that if we eliminate salt and water chronically in a large amount, then there is chance of development of the hypovolemia, especially in the hypertension patient. So heart failure patient, already they are hypervolemic because of decrease in the renal perfusion. GFR is already low, so there is significant water is accumulated already. So in hypervolemic patient, this is not a problem. But in hypertensive patient only, without hypervolemia, if we use furosemide for long time, then there is chance of development of the hypovolemia, and that will cause significant reflex sympathetic nervous system stimulation, and that will promote further vasoconstriction in the long run, then that will tend to cause increase in the blood pressure. So the reason of the using thiazide in hypertensive patient is that there is less chance of the reflex sympathetic stimulation with thiazide, and there is less chance of hypovolemia with thiazide, because in hypertension we need to reduce the BP only. There is no need to reduce the blood volume significantly as done by the furosemide. So furosemide is preferred in the heart failure, because we have to eliminate large amount of the water and salt from that hypervolemic patient. But in hypertension, patient is not hypervolemic. That's why if we use furosemide for long term, then there is a chance of development of the hypovolemia, and that will cause reflex sympathetic stimulation, which will cause increase in the blood pressure due to sympathetic stimulation. So thiazide is preferred, as antihypertensive. Sometimes if BP is significantly raised, often we add furosemide to reduce the BP for that time, but furosemide should not be used for continuous disease. Thiazide can be used, and it is caused why the thiazide is used. The thiazide inhibit the sodium chloride import in the early distal convoluted tubule, and this will promote salt and water excretion, and ultimately if it is sodium is lost, it has been found that sodium loss will actually help in the decrease in the vascular stiffness, and that will cause decrease in the afterload. So if sodium load is eliminated from our body, then vessel become less stiff and there is improvement in the blood supply, decrease in the afterload. So ultimately, as thiazide also decreases the body volume to some extent, so there is decrease in the cardiac output in the blood pressure, and sodium concentration in the vascular vessel decrease will cause less stiffening of the blood vessel, so there is decreased peripheral vascular resistance, and that will cause decreased blood pressure. And remember, among the thiazide and furosemide, thiazide causes more sodium loss. Sodium hyponatremia is caused mostly by the thiazide. That's why there is further decrease in the peripheral vascular resistance due to less stiffening of the blood. So now, why there is more loss of the more hyponatremia with thiazide? That is also depending on their site of action. So thiazide acts late and furosemide acts proximally in the kidney, in the renal tubule. So as diuretics, loop diuretics block the sodium absorption, but that sodium is again reabsorbed from the distal tubule or collecting duct to some extent. So sodium loss is not so much significant here, whereas thiazide acts late, and as they decrease the sodium absorption there, after that there is less chance of sodium reabsorption again. So the sodium which are blocked at the loop of Henle, the site of action of the furosemide, that most of the sodium is again reabsorbed from the distal tubule, whereas as thiazide acts in the distal tubule, so there is less chance of reabsorption of those sodium again from the collecting duct. So that's why there is more sodium loss with the thiazide ultimately, and as there is more sodium loss, thiazide will cause more hyponatremia, and in the distal tubule there is also a sodium potassium exchanger. So as more sodium is lost, there is more potassium is exchanged. That means thiazide will cause more hyponatremia but less hypokalemia, whereas furosemide does the reverse. There is less hyponatremia but more hypokalemia. That means in the distal tubule there is most of the sodium which is blocked by the loop of Henle due to furosemide action, that is reabsorbed, but potassium is eliminated. That's why remember this difference. Furosemide will cause more hyponatremia, less hyponatremia, more hypokalemia. Thiazide will cause more hyponatremia but less hypokalemia because of the late sodium channel block. That's why there is less chance of again sodium reabsorption by the thiazide. So what are the adverse effects of thiazide? It can cause hyponatremia, hyperglycemia, hyperuricemia, hypercalcemia, and due to this hyperglycemia there is also adverse effect like hyperlipidemia also, and impotence, decreased libido, and low dose is preferred up to 12.5 milligram. 25 milligram will have some adverse effects, so 6.25 to 12.5 milligram is preferred as thiazide. And thiazide diuretics, among the thiazide diuretics we commonly prefer chlorthalidone. Now it has been found that this electrolyte imbalance is less with the thiazide, this chlorthalidone. Sympatholytics, we have discussed beta blockers. So beta blockers, they act in the, what are the mechanism of action of the beta blockers? They decrease the cardiac output, they decrease the heart rate by beta 1 action, they decrease the cardiac contractility beta 1 action, and they decrease the sympathetic outflow also. Central sympathetic outflow is decreased, decreased heart rate, decreased force of contraction, and ultimately there is decreased cardiac output. And also at the beta 1 receptor as present in the renin, there is a decreased renin release, so there is decreased angiotensin aldosterone formation, that will also cause decreased salt and water retention, and that will also help in the reduction of the blood volume. So beta blockers mainly useful in the young hypertensive with increased renin activity associated and of course beta blocker is not a first line drug, but if beta blocker, if hypertension is associated in patient of angina, macular infarction or migraine, then beta blocker is a very good drug and can be given initially. Patients receiving vasodilators to counteract reflex tachycardia. So we have discussed that often amlodipine group of drugs tend to cause reflex tachycardia, and beta blocker is often attached to that to control this tachycardia. So beta blockers, mainly preferential beta 1 blocker is given. Example, metoprolol, atenolol, bisoprolol. So they decrease the cardiac output, they decrease the contractility, they decrease the heart rate, as well as by decreasing the renin release, they will also cause the block of the SAC. So the aldosterone production is less. And propranolol is non-selective beta blocker. They also can be used as antihypertensive, but nowadays not preferred because beta 2 block is not so much important. Propranolol blocks the beta 2, which is beta 2 blockage actually will cause vasoconstriction sometimes because beta 2 is vasodilator. So if beta 2 is blocked, there can be vasoconstriction, and there is often chance of increasing the peripheral vascular resistance. So in the long run it is not so much important, but in the acute setting, if propranolol is given due to beta 2 block, there can be development of the increased peripheral vascular resistance, which is not having beneficial effect in the hypertensive patient. Next, alpha adrenergic blockers like prazosin, tiodosin, doxorubicin. They are selective alpha blockers which is commonly used. Non-selective alpha blocker is preferred in the patients of the pheochromocytoma, that is a tumor of the adrenal medulla where there is excess release of the adrenaline from the adrenal medulla. So phenoxybenzaimide, phentolamine are non-selective alpha blocker, and prazosin, tiodosin are non-selective alpha 1 blocker. The alpha 1 blocker, they only cause vasodilation by alpha 1 blocking the alpha 1 receptor in the vascular smooth muscle. So, and remember this beta blocker thiazide, they have some adverse effects. So beta blocker tend to cause lipid hyperglycemia, tend to worsen the hyperglycemia, and also beta blocker tend to cause rebound hypertension if it is used, if it is suddenly stopped. But alpha blocker do not have such effects. That's why alpha blocker has metabolically safe. There is no chance of electrolyte imbalance and also no chance of the rebound hypertension in patients of the hypertension. That's why alpha blocker is also often if patients have multiple comorbidity like chronic kidney disease or multiple electrolyte imbalance, then alpha blocker is the preferred drug. Centrally acting sympatholytics, example is clonidine and alpha-methyl dopa, and they cross the blood-brain barrier and stimulate the alpha 2 receptor in the vasomotor center. So clonidine is the alpha 2 agonist. Remember this. So prazosin is the alpha 1 antagonist we are using in alpha as antihypertensive, but clonidine is alpha 2 agonist. They help in the reduction in the central sympathetic outflow from the vasomotor center, and that lead to decrease in the heart rate and decrease peripheral vascular resistance, that decrease in the BP. So why alpha 2 agonist is given? So alpha 2 receptor present in the presynaptic nerve terminal also, and they act as autoreceptor. So if alpha 2 is stimulated chronically, then there is reduction in the discharge from the central sympathetic system, and there is so from the vasomotor center there is less discharge of the norepinephrine, epinephrine. So there is less stimulation of the alpha 1 receptor present in the vascular smooth muscle. So when there is alpha 2 agonist is given, due to chronic stimulation of alpha 2, which is an autoreceptor, that will decrease the release of the norepinephrine, epinephrine from the presynaptic neuron, and thus there is less norepinephrine, epinephrine effect on the alpha 1 receptor present in the vascular smooth muscle. So thus there is reduction in the peripheral vascular resistance and improving the afterload. So alpha 2 agonist is used, which is act as alpha 2 act as a autoreceptor, so they will decrease the further release of the norepinephrine, epinephrine. But in acute setting, if it is given suddenly, then alpha 2 receptor present in the vascular smooth muscle to some extent, that will cause also hypertension, that will cause increased peripheral vascular resistance. So alpha 2 present in the centrally, present also in the blood vessel. Alpha 2 centrally acts to reduce the effect of the norepinephrine, but alpha 2 peripherally, which are present in the vascular muscle, they tend to cause vasoconstriction. So suddenly we cannot give clonidine dose, which can cause if clonidine is given at a large dose suddenly, that will cause vasoconstriction due to alpha 2 effect present peripherally. But if we use in lower dose for chronic basis, then there will be decreased norepinephrine release from the central sympathetic system, and that will cause decrease in the blood pressure. Adverse effects, there can be dryness of the mouth and eyes, there is sedation, bradycardia, and erectile dysfunction. There, and silent withdrawal is also not advised, that will cause some rebound hypertension. Apart from the hypertension, chlorine can also be used in opioid withdrawal, diabetic neuropathy, especially diabetic gastroparesis associated with some diarrhea, and often it can be used as pre-anesthetic medication. And vasodilators, hydralazine is a direct arterial dilator, can be given orally, but vasodilators tend to cause sympathetic stimulation, that's why it can cause reflex tachycardia, palpitation, sodium water retention, and can be countered by giving with diuretic or beta blocker. So other side effects are hypotension, flushing, angina. Because of this increased reflex tachycardia, it is not preferred in giving in MI patient, myocardial infection patient. If there is reflex tachycardia, then there is sudden development of there is increase in the oxygen demand, which is not needed actually, and rarely it can cause lupus erythematosus. Drug-induced lupus erythematosus, hydralazine is a common example. So remember, this is an arterial dilator. It is not a first-line drug, can be added later. Minoxidil, it is a potassium channel opener. It causes hyperpolarization of the vascular muscle and vascularization and decrease in blood pressure. It is used to promote the hair growth. So minoxidil, though used as a antihypertensive, but commonly its use is now as a drug for baldness. That means actually previously minoxidil, it shows that there is abnormal hair growth in female, and actually this is an adverse effect. So that's why this adverse effect is now utilized as a treatment of baldness. So as there is unwanted hair growth with minoxidil, but that's why minoxidil topical is commonly used in the scalp to treat the baldness or hair fall. Okay. So diazoxide also, that is vasodilator, can be used in treatment of the hypertensive emergency. So far we have discussed most of the antihypertensive drugs: ACE inhibitor, ARB, calcium channel blocker. Among them there is amlodipine, verapamil, lithiazine. We have discussed diuretics. Among the diuretics, potassium channel potassium diuretics like spironolactone can be also added if there is also sometimes patient's blood pressure is not controlled when you're giving 3 or 4 drugs. Then it is often the commonest cause is primary hyperaldosteronism. That means there is excess aldosterone activity which is causing the uncontrolled blood pressure. If we give spironolactone, then that is the aldosterone receptor antagonist, then effects of this primary hyperaldosterone can be diminished. That spironolactone helps in a great way in managing this primary hyperaldosteronism and thus control BP in those patients. So spironolactone can be given along with other drugs if blood pressure is not controlled after giving 3 or 4 drugs. And this is called resistant hypertension actually. So resistant hypertension means when we fail to achieve the target goal of the blood pressure, which is below 130 to 8/80 in most of the patients. Usually below 130, actually below 80 should be the target. If we fail to achieve the target by giving 3 drugs in their optimal dose, then and if it is controlled with spironolactone, then it is called resistant hypertension. So actually resistant hypertension means failure to achieve blood pressure, target blood pressure after giving three separate group of antihypertensive drugs in optimal dose. And commonly resistant hypertension is treated by the adding spironolactone, or we can give, you have to treat the cause actually. Often resistant hypertension actually is the result of the secondary hypertension. Unless we treat the cause of secondary hypertension, then hypertension is difficult to manage. So antihypertensive, it is very important oral course viva question, which should be avoided in pregnancy. Diuretics, because risk of the decreased blood flow to the fetus, as there is decreased blood volume with the diuretics, so there is decreased blood flow from the placenta and baby can have decreased blood supply and it can cause stillbirth. ACE inhibitor and ARB also they are teratogenic. Beta blocker, they tend to cause neonatal bradycardia and low birth weight, hypoglycemia. That's why ACE inhibitor, among the first line drugs, ACE inhibitor, ARB, diuretics, beta blocker, all should be avoided in pregnancy. Calcium channel blocker can be given. What is the safe drug? We prefer alpha methyl dopa. That is also action is similar like the clonidine. Alpha methyl dopa also decrease the central sympathetic outflow from the vasomotor center, and they will causing decrease in the norepinephrine epinephrine effect peripherally. calcium channel blocker we can give, hydrolyzin we can give, pyroxine we can give, and clonidine. Cardioselective beta blocker sometimes given if blood pressure is difficult to manage, especially labetalol can be given. So safe drug in pregnancy, drug of choice is alpha methyl dopa, and we can give calcium channel blocker, hydrolyzin, clonidine, pyroxine, etc. So this is the guideline for management of the hypertension. So as per the there are multiple guidelines, but this is easy to follow guideline. So among it has been found that patients among of hypertension who are aged more than 55 years, then the calcium channel blocker are the first choice, whereas patients aged less than 55 years, then ACE inhibitor is the first choice. So because in aged more than 55 years, then afterload reduction seems more important, whereas age below 55 years, then we have to reduce both preload afterload as well as reduce the blood volume. So ACE inhibitor do both. That's why it is preferred in the patients aged less than 55 years. So ACE inhibitor or ARB, A stands for those that, and calcium channel blocker preferred in the age more than 55 years. If it is not controlled with one drug, we have to go to the combination, that means A plus C. So in both the groups, whatever be the initial drug, we can add the combination ACE inhibitor or ARB plus calcium channel blocker in the step 2, A or C, A plus C or C plus A. If it is not controlled, then we add D, that is the diuretic. So this is step 3. And if it is step 4, that means if we are giving ACE inhibitor, calcium channel blocker, diuretic to an optimal dose, but BP is still above the target, then it is called resistant hypertension, and we have to add other group of drug like spironolactone or alpha blocker or beta blocker, and often we need special advice. So remember this flowchart, we have to select the drugs as per this flowchart, and remember now commonly it is now followed that if it is patient is in stage 1 hypertension, we start with one drug, and if it is failed to achieve the control within 2 or 3 months, then we add the second drug. But if it is stage 2, suppose patients come in the BP range 170 by 105 initially, then we give 2 drugs from the very beginning of the separate drug, and for that also we give this combination ACE inhibitor plus calcium channel blocker. So remember this, that's why staging is important. Staging, if it is stage 1, then we start with one drug. If we go on to adding other drugs, the BP is still above control. But if it is stage 2, we diagnose it as stage 2 hypertension, then begin with the 2 drugs, and if it is not controlled, then add the third drug. So stage 2 hypertension cannot be treated with the one drug. And if it is more than stage 2, that means if it is hypertensive urgency, BP is more than 180 by 120, then start treatment with the 3 drugs. So drug to be avoided in specific conditions. Remember, asthma, beta blocker is avoided because beta blockers, there is beta 2 will cause beta 2. If it is non-selective beta blocker is given, beta 2 receptor block will cause bronchoconstriction and will aggravate the respiratory distress in the asthma and COPD patients. Peripheral vascular disease also beta blocker is avoided because peripheral vascular disease means beta blocker will cause then the remaining adrenaline, noradrenaline will act on the unblocked alpha receptor. That means the alpha mediated vasoconstriction will be higher, and that will cause further increase in the peripheral vascular resistance, further reduction in the peripheral blood flow, and peripheral vascular disease will be worsened. Beta blockers also avoided in diabetes because beta blockers will cause decrease in the insulin release. Hyperlipidemia is also common adverse effect of thiazide beta blockers. So beta blockers thiazide should not be given in hyperlipidemia. Thiazides we cannot give it in patients of the hyperuricemia because already patients having hyperthiazide disease causes hyperuricemia as an adverse effect. Also thiazide is not preferred in the diabetes also because thiazide will cause hypokalemia. All diuretics actually cause hypokalemia, and hypokalemia will cause decreased insulin release. And in patients having some erectile dysfunction also beta blockers and diuretics, alpha blockers should be avoided. So remember these specific conditions where we have to select the antihypertensive drugs. We have to avoid some antihypertensive drugs. But remember few conditions where some antihypertensives are preferred. Like in pregnancy we have discussed, we prefer alpha methyl dopa. In diabetes we prefer ACE inhibitor ARB because apart from its antihypertensive action, diabetes ACE inhibitor ARB will also reduce the diabetic nephropathy because they reduce the proteinuria, and reduction of the proteinuria will help in the reduction in the change in the glomerular sclerosis. The glomeruli, there is excess ischemic deposition will cause further reduction in the GFR because of this glomerular sclerosis due to proteinuria, and ACE inhibitor will prevent that. And also, if it is patients having hypertension associated with benign hypertrophy of prostate, then alpha blocker is the drug of choice like prazosin. They will cause both reduction in the blood pressure as well as improve the symptom of the prostatic hyperplasia. They will improve the urinary outflow. And also, if it is patients having ischemic heart disease or overactive sympathetic stimulation, suppose patient is young hypertensive, he is having increased sympathetic overactivity, like patient having increased sweating, increased heart rate, then also beta blocker is the drug of choice. So we have to select the drug as per the patient profile. In diabetes we prefer ACE inhibitor ARB. In patients of angina, hemoglobin infarction, we prefer beta blocker. In patients of hyperplasia prostate we prefer alpha blocker. In patients of concomitant heart failure with hypertension, then we have to prefer and diuretics. In patients of the hyperaldosteronism we prefer spironolactone, and in patients of pregnancy, in pregnant women we prefer alpha methyl dopa, hydrogen, chlorine, etc. So remember these specific uses of specific drugs. And next is hypertensive crisis. So the hypertensive crisis, what is the drug of choice? Remember, the hypertensive crisis means it can be either emergency or urgency. In urgency means we have to give oral drug, and emergency means we have to give IV drug. Remember, the IV drug is the drug of choice is sodium nitroprusside or labetalol. In hypertensive emergency we have to give it in IV, and for oral drug we can give captopril, nifedipine, also labetalol. So often 2 or 3 drugs is combined in treatment of the hypertensive urgency or emergency. In emergency, labetalol 80 to 120 milligram IV, 80 milligram IV stat followed by 80 to 120 milligram IV every 10 minutes until BP is controlled. So remember, blood pressure should be controlled in hypertensive emergency. Blood pressure should be controlled within 2 hours, and preferably it should within 2 hours. 25% reduction of the mean blood pressure is important. And what is mean blood pressure? It is systolic blood pressure plus 1/3 of the pulse pressure. Systolic blood pressure, mean blood pressure is diastolic blood pressure plus 1/3 of the pulse pressure. That means pulse pressure means systolic and diastolic pressure different. So suppose systolic blood pressure is 200, diastolic blood pressure is 140. What is the mean blood pressure? Mean blood pressure is 140 plus 1/3 of minus difference between 200 and 140, that is 60. So 140 plus 30, 1/3 of this 60, that is 20. That means 160 is the mean blood pressure if BP is 200 by 140. So you need to reduce the blood pressure by 25%. Mean blood pressure 25% means 160 25%, that is 120. 160 25% is 40. That means we have to reduce the mean blood pressure by 40 from 160. That means we need to reach the mean blood pressure of 120 within 2 hours. How that can be achieved? If suppose blood pressure is around 150 by 100, then mean blood pressure is close to 120. So we have to target the blood pressure, and we can increase or decrease the drug dose as per the response. So remember, hypertensive emergency, we need to reduce the blood pressure within 2 hours. Mean blood pressure will be reduced by 25% within 2 hours, and drug of choice is either sodium nitroprusside or labetalol. Labetalol is a combined alpha plus beta blocker, and it is available both orally as IV, and even labetalol is the drug of choice in hypertensive emergency in pregnant women also. So write down the few questions. Number 1, why thiazides are preferred antihypertensive over furosemide? Number 1, why thiazides are preferred over antihypertensive over furosemide? Number 2, Mechanism of action of the thiazide as antihypertensive. Number 3, why beta blocker is not combined with diltiazem. Why beta blocker is not combined with diltiazem. Number 4, safe drug to be used in pregnancy. Safe antihypertensive to be used in pregnancy. Number 5, which drug is preferred in diabetes? Number 6, which antihypertensive drug is preferred in patients of angina? Number 7, drug of choice for the hypertensive emergency. Number 8, what drug will you give if a patient has BP of 170 by 104? What drug will you give in a patient if BP is 170 by 104? Number 9, common adverse effect of the diuretics as antihypertensive. Common adverse effect of diuretics as antihypertensive. Number 10, give example of two arterial dilators. Give example of two arterial dilators.